in our society. नहीं हो डिस्क चेंजर काम कर slides. So aim of presentation is that how we can minimize the chances of errors in glaucoma diagnosis. Usually glaucoma is a straightforward diagnosis, but there are sometimes diagnostic challenges. And if we follow a systematic approach, it can minimize the chances of errors in diagnosing glaucoma. So let's start from the basics. What are those things? What is that checklist that we should be doing so that we cannot miss glaucoma? Usually the glaucoma diagnosis depends upon a good history, a good clinical examination, and relevant investigations. So these three pillars, they can add in our glaucoma diagnosis and its management. But sometimes, even despite these things, there are challenging cases like glaucoma suspects, myopes, comorbid retinal conditions, disc abnormalities, neurological conditions. So even in the presence of these sophisticated diagnostic tools, we face these challenges. So to minimize those errors, different societies, glaucoma societies all over the world, they have developed few guidelines. Like American Academy of Ophthalmology, they have their own preferred practice patterns for primary open-angle glaucoma. Then we have Canadian Ophthalmological Society guidelines for glaucoma diagnosis. Then we have the European Glaucoma Society, their own guidelines for glaucoma diagnosis. Asia Pacific Glaucoma Society. These are few of the one which I'm going to mention. The AICO guidelines for glaucoma eye care. And in the end, Pakistan Glaucoma Association guidelines, they have recently updated these guidelines. I'm going to talk about the last two guidelines, the AICO guidelines and PGA guidelines, and what are those checklists which we have to fill when we are dealing with glaucoma patients. So when we are talking about AICO guidelines for glaucoma eye care, there are 19 items from the three elements, and these three elements are history, examination, and investigation. As I said earlier, that all glaucoma diagnoses that revolve around the good history, examination, and investigation. So in history part, what AICO recommends is that each patient should be asked about these 8 items, like chief complaints about their biodata, what is the family history of glaucoma, past ocular history, current ocular medications, systematic medication, any addictions, any systematic disease like diabetes, hypertension, migraine. It should be asked from each patient if they are being evaluated for glaucoma. Ye screen nahi aa rahi. So these are those checklists we have to ask in history. Then coming to the examination. In examination, visual acuity, the refractive error, pupil reaction, it is one of the most important clinical examination we have to check. Anterior segment examination in glaucoma, it is also very important, like in pseudoexfoliation, Kruger-Wenberg spindles, these different, any trauma-related anterior segment abnormalities, eye syndromes, you have these iris abnormalities, you have to check accordingly. Then IOP measurement, gonioscopy, optic nerve evaluation. Optic nerve evaluation is very important clinically. We have to check the size of the disc, the size of the cup, the color of the rim, the size of the rim, nerve fiber layer, any defects. All we have to check in this optic nerve. Then fundus, in fundus we have to check the macula, the vessels, and the retinal periphery. So in examination, these all have to be checked if we are dealing with glaucoma patient. Then in the end, investigations. So AICO, they recommend that for each glaucoma patient, the central corneal thickness should be measured, the visual fields should be done, and the optic nerve head or nerve fiber analysis, that should be done. This imaging should be done. So there are 19 items they have listed, and there are 3 elements. This should be done for each of the glaucoma patient if you are dealing it. Now coming to the PGA guidelines. Again, PGA guidelines also have these 3 main pillars like history, examination, and investigation. Again, in history, almost the same things they have said that you have to check about the ocular history, any ocular symptoms, personal history, family history, all those things. Similarly, in examination, they have same elements, same items like of the ICO guidelines. But what they have, excuse me, so what they have added in their investigations, apart from the pachymetry of OCT and visual field, they have added the corneal hysteresis and OCT angiography. Now, corneal hysteresis and OCT angiography, they can be helpful in certain cases which cannot be diagnosed or which, on these routine investigations like optical coherence tomography and visual field analysis. So this corneal hysteresis and OCT angiography, these are added by Pakistan Glaucoma Association guidelines. So when changer काम नहीं कर रहा. So now we have done with the checklist. Now, what actually is happening in our setup? How people are diagnosing glaucoma? How they are doing their work about glaucoma? So we have conducted our study. Our title was that compliance with International Council of Ophthalmology guidelines for glaucoma eye care among ophthalmologists in Pakistan. Now we have sent this paper for publication in Journal of Glaucoma, and hopefully it will be published soon. I'm just going to give you a few of the results, not whole paper, but just glimpse of these results. What were our aims? Our aims were to determine what are the compliance levels of Pakistani ophthalmologists with ICO guidelines, and we also compared the practices between the ophthalmologists who are working in private and public healthcare settings. Our methods were, we reviewed all the charts, those patients who came to our glaucoma clinic. We evaluated their charts. The study spanned from September 2021 to January 2023. And these charts were reviewed according to the ICU guidelines, which included all those 19 items. A total of 394 records were analyzed. Males were more as compared to females, and the private setting, these prescriptions from the private settings, that were more as compared to the prescription from the public or government settings. And primary open-angle glaucoma was the most common diagnosis. So this, I want to highlight what is happening in our setup. So if you can see this column, the last column, the compliance level, you can see in history part, we all had low to moderate compliance level. And if you see the addictions, like if you see did the ophthalmologist or eye doctor asked about the addiction, so it is 0. Nobody did ask about any addictions. So it was 0% in this element. And rest of the chief complaints, biodata, family history, past ocular history, eye medication, systematic medication, disease, all had low compliance levels. Coming to visual, the examination. In examination, again, there was low to moderate compliance level. You can see the gonioscopy, only 2.5% of the ophthalmologists, they did gonioscopy on their patients. So it's very low level of compliance. Even if you see the IOP measurement, 86% people checked IOP in their settings. So again, we are saying that glaucoma is all about IOP, and again, you are just checking IOP in 86%, means we are not doing justice to our patients. In investigations, corneal thickness, visual fields, optic nerve head imaging, again, low level of compliance. CCT has 4.6%, visual field has 5.8%, and overall the mean compliance was 6% in examination part. So you can see what is actually happening. We are either at low or the moderate level. In most of the cases, we are at low levels of compliance with the ICO guidelines. So our conclusions were that Pakistani ophthalmologists, they need to gain knowledge about the ICO guidelines for glaucoma eye care. And our study, it emphasizes that these guidelines should be included in the general ophthalmology curriculum. So take home message from this presentation to all would be that this checklist should be kept in mind when you are dealing with glaucoma. And since now the PGA has updated its guidelines about glaucoma, and it better fits to our demographics, I would request all ophthalmologists who are dealing with glaucoma that they should go through those guidelines and at least follow it in their setup. And if they are teaching their residents, they should teach their residents how to follow those guidelines in managing their glaucoma patients. Thank you, everyone.
Thank you very much, Dr. Yusuf Jamal, for very interesting talk on basic things about glaucoma, and it is an eye-opener for us that most of our colleagues or even us are missing some of the basic parts of glaucoma assessment. So with this, we move to our next presentation, that is by Professor Sadia Farooq, and the topic of her presentation is on the evaluation of disc. The disc is king. So Professor Sadia Farooq is requested to please come on the stage. Thank you.
Bismillahirrahmanirrahim. Thank you very much, Dr. Mahmood. So I'll pick one component out of the checklist of Dr. Yusuf, that is clinical examination of optic disc. So optic disc is a site of damage in glaucoma. So best thing to look at for this damage is to look at the optic disc. There will always be a role of clinical examination of optic disc, no matter how many investigations come up. And look at the disc, you will find glaucoma in your patient. Objective of today's discussion is to focus on how we can diagnose glaucoma, we can detect progression, and how we can exclude differential on clinical examination of optic disc. Before we go into pathology, first of all, let's have a look at the normal disc. Normally, it is a hole in the sclera through which 1.25 million nerve fibers leave the eyeball. They are focused towards periphery to form a neuroretinal rim. And the central part is devoid of any nerve fiber. That is why we see a color contrast. We look at the differentiation of cup and neuroretinal rim by looking at the angulation of blood vessels and not the color contrast. So normally we have a vertically oval disc and a horizontally oval cup, and it follows the Ising rule. Size of the cup varies among individuals. There must be a set way of looking at glaucoma optic disc, and for that we follow the mnemonic of SHIP: size, hemorrhage, Ising rule, atrophy, and RNFL defects. It's very important to look at the size of the disc. This concept was introduced by Amle, and later on it was strengthened by Spaeth, who has devised disc damage likelihood scale. He has also incorporated neuroretinal rim width in it, and he categorized the disc as a small, medium, and large discs. Disc size is important, and it varies. Size of the cup varies with the size of the disc, and it's linearly related. If we do not look at the size of the disc, we can miss the diagnosis of glaucoma in eyes with a small optic disc, and we can misdiagnose glaucoma in patients who have large or asymmetric discs. So top is the example of a small disc, and very small cup expansion is missed unless we look at beta peripapillary atrophy, which is a sign of glaucoma. In the middle, a generous cup in a small disc is abnormal because we see an fibular defect with it. And in the lower pair of pictures, what we see as one disc looks abnormal. But again, if you focus at the size, you will see that the large looking disc is actually a 1/3 larger in size, and it has a corresponding larger cup, so it's also normal. So this is asymmetric cup disc. On the other hand, a large optic disc that may look suspicious basically has a large cup, and it has a uniform neuroretinal rim width, which is normal on RNFL and red-free photograph. So how to measure disc size? If you use an ophthalmoscope of 5 degree, the spot size is equal to 1.5 millimeter, which is equal to the size of the disc. If we are using slit lamp, we must keep in mind that 90 diopter lens, we must add a correction factor of 1.36. The second thing to look at is neuroretinal rim. Neuroretinal rim is a site of damage of glaucoma, so we must look at it carefully, superiorly, inferiorly, laterally, and medially. And it follows the Ising rule. Ising rule means that the inferior rim is thicker than the superior, and that is thicker than the nasal, which is thicker than the temporal one. Different discs respond differently to rise in intraocular pressure. There can be generalized concentric enlargement of the cup. Because this enlargement is happening all around, that's why we do not see early a visual field defect. On the other hand, if we see a focal neuroretinal rim loss, then we usually see a visual field defect because the loss of tissue is more at one side. From our knowledge, we know that the supratemporal, infratemporal are the most superficial fibers. So these are the first to go in glaucoma. So that's why we see now vertical elongation of the cup and thinning of neuroretinal rim. We can see a combination of both. Sometimes you see more pallor than cupping. Pallor is usually suggestive of an ischemic damage and associated with neurological disease. Sometimes with very high pressures, pallor can develop. So pallor means color contrast is missed, and now we do not see any differentiation between neuroretinal rim and the cup. If you look at the blood vessels angulation is normal. So here is to differentiate between cupping and pallor. In the top pair, we see expansion of the cup, angulation of blood vessels, thinning of neuroretinal rim, which is suggestive of glaucoma. Whereas in the lower pair, we see that the color has faded and the blood vessels are same. So it's most likely it's a neurological disease. Saucerization is another form of cupping with temporal sloping walls, and it is difficult to differentiate the edge in it. It is generally seen in atherosclerotic disease. So other features of glaucomatous optic neuropathy are longevity of the central vascular trunk, Z-shaped angulation of blood vessels, thinning of the vessels at the edge of the disc, then laminal pore sign, and finally beta peripapillary atrophy. We must keep in mind that glaucoma is a laminopathy. The lamina cribrosa is the primary site of glaucoma damage. Because of elevation of intraocular pressure, there is posterior displacement of the lamina. So in glaucoma, we see deepening of the cup as well. If this is missed, we might be suspicious of the diagnosis of glaucoma progression then. Optic disc hemorrhage is a red flag for diagnosis and progression of glaucoma. It is very specific for it, more commonly seen infratemporally than supratemporally. It is usually transient and may disappear in 3 months' time. Ocular hypertension study has found its correlation 6 times high risk of progression to glaucoma in those patients. Wherever we see disc hemorrhage, there is a more fear or risk of rim loss, thinning, and RNFL defect, and finally peripapillary atrophy. RNFL defects are visible in those patients who have large, highly pigmented retinas, and it is seen as a wedge-shaped defect. It is suggestive of glaucoma damage at that side. Usually we see neuroretinal rim thinning with it as well. So it's not just increase in cup disc ratio. We have a lot of signs that we look at the optic disc and we say that the patient has developed glaucoma, and more signs are there, more and more pathognomic of glaucoma it is. We look at the progression of these signs to monitor progression of glaucoma, thinning of rim, widening of notch, peripapillary hemorrhages, vessel shift, increased atrophy, and widening of RNFL defect. Over the time, we see the cup expanding. It is expanding vertically. There is thinning of the inferior neuroretinal rim. It's not following the Isent rule. So this is progression of glaucoma. We see thinning of rim along with angulation of blood vessels. So for that, we have to look all around the disc if we want to monitor progression. And now we see more angulation here. So this is progression. Increased beta peripapillary atrophy is considered as a sign of progression of glaucoma. Collateral developments. And out of shift, we see peripapillary hemorrhage here. We can compare stereo pairs, and on comparison, we see that there is no change, so it means this is not glaucoma, it hasn't progressed. It's not glaucoma at all. On the other hand, vertical notching is a sign of glaucoma, rim thinning. And this is progressive glaucoma. We see hemorrhage, and then we see thinning along with it. To exclude other differentials, we know the most important differential is ischemic optic neuropathy. Pallor and RNFL atrophy without rim excavation is seen in ischemic or neurological diseases. One of my patients had giant cell arteritis, and there is no change in lamina over time, although he developed progressive thinning, progressive pallor. On the other hand, disc edema and drusen's are differentiated on the same basis that patient has pallor and no excavation. So basically, just to sum up, that glaucoma is a disease that causes loss of both nerve tissue and connective tissue, and it is a laminopathy. Thank you very much.
Thank you, Professor Sadia Farooq. Now we move on to our next presentation, and that is by Professor Afzal Bodla, but his co-presenter, Ms. Rabia Rahman, will present the case, and diagnosing the glaucomatous changes among high myopes. So very interesting topic, and it's always a challenge to diagnose glaucoma in myopes. Quite confusing things sometimes, even it takes a lot of clinical acumen to differentiate between these changes and myopic changes and glaucomatous changes. Please.
And the topic is diagnosis, glaucomatous changes among high myopes in southern Punjab based on CPRNFL and macular ganglion cell complex thickness. This is important topic. Important topic to avoid to misdiagnose patient high myopes with glaucoma. Now let's start a brief overview of glaucoma. Glaucoma is the world leading cause of permanent blindness and progressive neurodegenerative disorder. Death of retinal ganglion cell produce structural changes that include thinning of the CPRNFL and macular ganglion cell complex thickness. What is myopia? As you people know, myopia is a refractive condition, parallel rays of light entering in front of the eye, entering and do not focus on retina, but focus in front of the retina. This is growing effect of myopia. In 2010, nearly 28% population affected by myopia. In 2020, the projection increased, nearly 50% population affected. Myopia as a challenge for early glaucoma detection. It is a risk factor for open-angle glaucoma. Early diagnosis of glaucoma in presence of optic nerve head changes and retinal characteristics in high myopia. Myopia is a unique challenge. Next slide, please. RFL thinning associated with myopia may mimic CPRNFL thinning associated with glaucoma, possibly lead to misdiagnosis. These changes in myopes make it difficult to distinguish glaucomatous optic neuropathy from myopia-related optic nerve retinal abnormalities. CPRNFL thickness changes were significantly lower in high myopia compared with those low to moderate myopia. The average CPRNFL thickness decreased with increase the axial length. The normal macular ganglion cell thickness approximately 95 to 100 microns. Change in 5 microns considered significantly in high myopes. Please change the slide. Objective of my study is to evaluate thickness of CPRNFL thickness and macular thickness in high myopia. Rationale of our study: increase in incidence of myopia and correlation with glaucoma has highlighted importance of myopia. Non-glaucomatous eyes to be excluded from glaucomatous eyes based on myopic refraction and different parameters of CPRNFL thickness and macular ganglion cell complex thickness. This is methodology of our study. The study include 80 eyes of 40 patients. Both gender will be included, 20 to 40 years of age, refractive error greater than -6 diopter. All patients were evaluated through history taking, comprehensive eye exam, best corrective visual acuity, slit lamp biomicroscopy, Goldman applanation tonometer, gonioscopy, fundus examination. Inclusion criteria: refractive error -6 diopter, spherical equivalent, patient with age range 20 to 40 years, both gender will be included, best corrected visual acuity 612. Exclusion criteria is low to moderate myopia is excluded. Age below 20 and above 40 will be also excluded. Visual acuity less than 612 excluded. Past refractive surgery, patient any type of glaucoma. Individual with systemic disorder and myopia also exclude. Now move on results. 40 participants are included in our study, age ranging 20 to 40 years. Among 40 participants were included, 23 participants were male, and 17 females. Frequency distribution on glaucoma suspect. In our study, non-glaucomatous patient 31 and glaucoma suspect case 9. The average RNFL thickness and GCC thickness of 40 patients 77.56 in RNFL thickness, GCC thickness 73. This is a criteria for diagnosing of a glaucomatous patient to exclude highly myopic patient. This is the left eye thickness 76, 72. Other study with comparison, 39 patients were included. Average thickness RNFL 88. The average MGCC thickness 78. In glaucoma suspect case, average 18 eyes, 9 patients were glaucoma suspect, whose RNFL thickness 71 and MGCC thickness 69. Same as left eye, average RNFL thickness 70 and MGCC thickness is 67. Other study comparison between RNFL thickness 77 and glaucoma suspect 62. The result of our study is p-value positive because similar results and other studies, RNFL thickness also decrease in high myopic patient, and GCC thickness is the main criteria for glaucoma diagnosing. But the criteria of in high myopes differential diagnosis, the RNFL thickness 71 and GCC thickness is 73. 5 to 6 micron difference between normal emmetropic eyes and high myopic eyes. This is comparison of both high myopes and glaucoma suspect case. 77 is the first criteria, glaucoma suspect 71. Same as MGCC thickness 73 in high myopes, 69 glaucoma suspect case. Conclusion of our study, refractive status significantly affected optic coherence tomography. Highly myopic eyes tend to have thinner RNFL and GCC thickness. CP RNFL thickness was more than MGCC thickness in high myopes, similar in ratio in glaucoma suspect. Normative database of OCT should be based on refractive error and axial length, which would provide us CP RNFL and MGCC thickness of high myopes, including glaucoma suspect in high myopes. Thank you.
Thank you, Ms. Rabia, for the interesting talk on high myopes. And now our next presentation is by Professor Sadia Farooq again, and the topic of her presentation is therapeutic strategies of neovascular glaucoma.
Thank you, Dr. Mahmood. This talk is, I think, a slight out of context to the topic of the session, not in the diagnosis, but anyway. So neovascular glaucoma is a vision-threatening secondary glaucoma, commonly seen as an end stage of retinal diseases. It's very important to diagnose these patients in time so that we can save their useful vision. So that's why we must have an idea of their pathophysiology, clinical features, diagnostic workup, and evidence-based medical and surgical guidelines. There is normally a balance between pro-angiogenic and anti-angiogenic factors in a normal eye, and the normal blood vessels of iris and retina are non-fenestrated with tight intercellular junction. VEGF is the main vascular promoting factor that is released from the retina in response to hypoxia. It diffuses from the posterior part of the retina, gets into the anterior chamber, and causes proliferation of tissue onto the surface of iris and into the angle, causing initially secondary open-angle glaucoma and then secondary angle closure glaucoma, and finally glaucomatous optic neuropathy. Many causes can be there, but most importantly, these are diabetic retinopathy, CRVO, and carotid occlusive diseases responsible for retinal ischemia. Classical clinical symptoms are pain and redness in the eye, and along with that, visible neovascularization on the surface of the iris in the angle, elevated intraocular pressure, synechial angle closure on conioscopy, and signs of glaucomatous optic neuropathy. Comprehensive ocular examination is needed, especially the role of conioscopy. It was found that 10% of non-ischemic eyes and 6% of ischemic eyes developed NVA without signs of iris neovascularization. We can miss iris neovascularization if we dilate the pupil, so it's the importance of undilated examination of those eyes that are prone to have neovascularization. RAPD, considering it as a sign of ischemia, and looking at the optic nerve. So we miss glaucoma in those patients. We are aggressively treating retinal ischemia, and we miss glaucomatous optic neuropathy that causes advanced glaucoma in these patients. Diagnostic workup, usually non-invasive, is done, OCT angiography and angiography of iris neovascles to detect ischemia early. We have European Glaucoma Society guidelines. It divides the management into two arms. One, directed on the treatment of retinal ischemia by performing PRP, and second, control of intraocular pressure. So a number of modalities are available to reduce hypoxia by PRP, anti-VEGF, cyclocryovitrectomy, treat macular edema by anti-VEGF, lower intraocular pressure medically with the help of anti-glaucoma medication, and then when needed, augmented trab and glaucoma drainage devices. Patients who have poor vision can undergo cyclocryotherapy. So we see a spectrum of disease moving from pre-rubeosis to secondary angle closure glaucoma, and prognosis going from good to bad. Usually in early part it is asymptomatic, but the studies have shown that 25% of patients who have NVI and NVA, they will develop glaucoma and high intraocular pressure. So we have a window time in which we can detect them early and can improve the prognosis of patient and preserve useful vision. And this is just the sum up of today's discussion. Once retinal ischemia is detected, PRP is currently the most common treatment to minimize ischemia. It must be done aggressively, 1,200 to 1,600 runs in short sessions as quickly as possible. If not possible, then vitrectomy is done. Studies have proven that long-lasting effect of PRP is better than anti-VEGF alone. Anti-VEGF fill in the blank by reducing inflammation and preparing the eye for surgery, and generally long-term efficacy is not proven in different studies. Once the pressure is high, then aqueous suppressants have the main role. Medicines that increase inflammation like PG analogs and that work in angle are not usually effective. Indications of surgical intervention are good vision and insufficient maximum pharmacological control of intraocular pressure, and when the angle is closed, medicines generally not work for long. Once the eye is made quiet with PRP and anti-VEGF, then usually incisional surgery is not performed when the active disease is there, and the recommended surgery is tube surgery with tube either in sulcus or in pars plana when it is combined with vitrectomy. Cyclodestructive procedures are reserved for those who have poor vision or when the tube surgery cannot be performed. So there's a long-term success of Mahmood et al. Has recommended 62.5% success at 1 year and 52.9% at 2 years in NVG patients. Because it is a refractory glaucoma, so surgery has to be combined with some certain modalities so that we can make it successful. Mitomycin is used in tube and trab in different concentration, use of digital massage afterwards, use of pre-placed releasable sutures so we can have a better control on bleb afterwards. To reduce inflammation, subconjunctival dexamethasone is injected post-operatively to reduce vascularization, intense steroid bleb needling whenever required, and ocular surface health by using preservative-free lubricants. So I'll just add a case how all this management will fit in. So one patient, 52-year-old, had NVI, had classical neovascular glaucoma with synechial angle closure. He was started on IOP lowering medication. He was given anti-VEGF, but the pressure rose to 42. So TRAB was done first, and then PRP started at 10 days and completed in 6 weeks. IOP controlled with surgery, and vision improved to 6/18. So needs collaboration of both glaucoma and retinal surgeons. timely collaboration. World Glaucoma consensus on NVG is reduction of ischemic stimulus in neovascular glaucoma is typically by PRP is better controlled. Anti-VEGF injections provide a useful adjunct for the treatment of neovascular when they are given prior to surgery, but reduce the risk of hemorrhage and provide temporary reduction of IOP, but do not provide long-term control. We have different surgeries. Data on direct comparison of different surgical options for neovascular are limited, and there is currently no clear superior surgical approach. With active neovascularization, TRAB should be avoided, and glaucoma drainage devices should be considered. Success rates are lower, and intra and post-op complications are higher for neovascular glaucoma surgery than for primary open-angle glaucoma. So this is one quoting of evidence improving outcome in neovascular glaucoma, that how with aggressive manipulation and close collaboration between glaucoma and retina specialists, we can improve the outcome of this serious disease. So in Peking University, a prospective study was done on 51 eyes. All eyes received immediately intravitreal anti-VEGF on NVG diagnosis. Then anti-VEGF injections were continued monthly until full PRP was completed. TRAB was done when it was needed, or cataract surgery and vitrectomy was also done in between. Overall, 100% of eyes that completed the treatment protocol had regression of anterior segment neovascularization, 93% stabilized with improved vision, and 87% have control of intraocular pressure at 6 months. So it means if we can timely treat neovascularization and timely take control of intraocular pressure by doing whatever modalities, we can have a better outcome. So just to conclude that besides combination of anti-VEGF, PRP, prompt IOP control, can offer routine management to reduce progression and damage and preserve vision in NVG patients. Thank you very much.
Thank you, Professor Sadia Farooq. Now the next presentation is Introduction and Overview of Glaucoma in Sindh by Sayyid Imtiaz Ali Shah Saab.
Bismillahirrahmanirrahim. All is spoken before. Glaucoma is a multifactorial optic neuropathy characterized by progressive structural loss of retinal ganglion cells that may result in vision loss and irreversible blindness, raised IOP being a risk factor. Glaucoma is the second leading cause of irreversible blindness across the world. Traditional definitions of glaucoma have been largely focused on raised IOP. There are presently two groups of ophthalmologists. The older group believes IOP is the main offender in glaucoma, and the younger group believes that optic neuropathy is the main offender in glaucoma. In the eye, IOP behaves like cholesterol in the blood. Cholesterol, when raised, leads to stroke by vascular obstruction, whereas cholesterol, when goes down, it causes stroke due to demyelination. IOP, when goes up, it causes glaucomatous damage, and if it goes down, it causes hypertony, choroidal effusion, detachment, and phthisis. My cause of concern about the state of glaucoma in Sindh is clear from a study done by our President-elect, Professor Mahar, sitting here in Karachi, capital of Sindh, which states that 17% of all glaucoma patients were legally blind at the time of presentation, and 50% of patients required intervention, mostly having drainage procedures. And as we know, drainage procedure is not done in early glaucoma. Therefore, almost 2/3 of the patients presenting in a major hospital in Sindh had severe glaucomatous damage. The diagnosis of glaucoma depends upon confirming progressive anatomical changes and functional changes, which needs basic diagnostic tools: fundoscopy, tonometry, gonioscopy, perimetry, papillary photography, OCT. All are not available in most of the ophthalmic facilities in Sindh. The most important consideration in the management of glaucoma is documentation of progression of visual loss, which needs basic tools which are not available in basic ophthalmic facilities across Sindh. Majority of glaucoma specialists would agree that IOP is certainly the most important risk factor in addition to age, race, family history, high myopia, diabetes, and others. Our goal in the management of glaucoma should be to achieve appropriate target IOP to halt visual field loss. Target IOP may be defined as a pressure level within which the progression of glaucoma and visual field loss will be halted. If we look here, in 1870, we had only one anti-glaucoma medication in the form of pilocarpine, and there was nothing till 1970. From 1970 onwards, we have anti-glaucoma medications. So for this 1 century, the senior ophthalmic surgeons were only managing the glaucoma patients with surgery. The method of treating glaucoma by ophthalmologists across the world is fairly straightforward. Begin with drops, add more drops, adjust drops, add more oral medication, try laser, and then do the surgery. I have reservations for this approach. In evident presence of poverty and lack of health education in Sindh, if you look into this picture, the lion represents glaucoma and the zebra represents the eye on anti-glaucoma medication. Keeping patients on anti-glaucoma drugs in Sindh is a risky decision. I recall a patient who lost the eye due to primary open-angle glaucoma only because he could not afford the medication. And the other thing is compliance. I would prefer to go for surgical option in Sindh unless there is some definite contraindication. Man proposes, God disposes. This should not be underestimated. I had a recent interaction with a patient. She had glaucoma at birth and was operated by me 22 years back. Due to non-availability of pediatric ophthalmologists, I performed trabeculectomy in both eyes in one sitting, and as usual, she disappeared. After 22 years, she reappeared. Her IOP in the right was 14 and left 12, corrected vision 6.9 in right and 6.6 in left. Her corneal diameter was 15 mm in right and 14 mm in left eye. And I asked her, where was she? She said, I was at home. I said, from where you are coming? She said, I come from a remote village near Larkana district. My mother told me that when you were born, you had white eyes. You were operated by Dr. Imtiaz Ali Shah at Larkana. And then we came back to our village, and your eyes started whitening and becoming clear. So we thought that you are now becoming all right, and we were so poor that we couldn't afford to visit you again. I said, how many times you have shown yourself or visited an ophthalmologist? She said, never, in 22 years. I said, then why you are here after 22 years? She said, 3 months back, I was married, And yesterday I asked a question from my spouse that why you proposed me? I'm a poor lady and you are son of a rich man. So what made you marry me? The reply is my concluding slide and remark. The spouse replied in Sindhi, Tujun vadin vadin sonin akhun mukhe mare chadyo. And you see, translating it in Urdu, तुम्हारी खूबसूरत बड़ी बड़ी आंखों ने मुझे तुम्हारा फरिश्ता बना दिया. And in English, I would say that he said, the spouse said that your big, beautiful eyes blinded me. So the message is we must keep on finding best remedies for this blinding disease, not forgetting the cost effectivity, although maintaining quality. This dream can only come true if we start thinking of developing our own industry rather than relying on ready-made remedies available in unaffordable cost. We must learn from setbacks of past and now start thinking of solving our own problems. Thank you very much for patient listening.
Okay, the last presentation of this session is by Dr. Noor Bakht Nizamani on eye stent inject. So after this we have a plenary session that will start at 6:30 p.m. So the last presentation.
Hello everybody. My talk is a bit out of context from this session because it's more of a therapeutic talk than a diagnostic talk. So I'm just going to present a small audit that we did on eye stent inject. So just a brief introduction of the eye stent. It's basically a minimally invasive glaucoma device. We have a lot of these minimally invasive glaucoma devices in market now, which have been developed as a bridge between the medical therapy and lasers and the trabeculectomy. So really these devices are very useful in buying us some time, even in advanced patients who are unwilling for trabeculectomy or tubes and other procedures. So this was produced by Glaucus and approved in 2012. The aim is to lower the intraocular pressure and possibly dependence on glaucoma medication. And it's usually indicated in primary open-angle glaucoma patients, and it's usually done in conjunction with the cataract surgery, but there are some standalone cases as well. Just a brief introduction. So you can see that small device in the corner, that's the eye stent there, and it's usually implanted in the trabecular meshwork, and it allows the aqueous to flow from the anterior chamber into the Schlemm's canal. Due to a natural episcleral back pressure, there is a very low risk of hypotony, which is usually associated with other bigger procedures like the trabeculectomy or tube surgery. These are the different versions of the eye stent. There's a G1, there's a G2, and that's the small injector that we use to inject. This isn't working, but you can see at the corners, these are the two eye stents. I have a small video as well, which I'll show you towards the end. So the objective of our audit was basically to see the efficacy of the eye stent inject in glaucoma patients, and we compared our trials, our results with the ID pivotal trial results. So the very busy slide, I'll just briefly tell you what the ID trial was. It was a 2-year randomized multi-center control, multi-center trial, which included over 500 eyes, and they compared the basic efficacy of phaco alone and versus phaco eye stent. And in their results, over 75% patients achieved control of 20% of the reduction in intraocular pressure as compared to cataract alone, which was only 60%. So our main outcome measures were the intraocular pressure and the number of drops. So this was done at 2 hospitals over a span of 4 years, and we included about 300 eyes. And it was split into two phases because one phase was done at one hospital and the other one was done at the other hospital. And patients included had at least a follow-up of 1 month post-op, and other patients were excluded, especially those who had early surgical intervention and insufficient follow-up. So the demographics, we had about 173 in phase 1 and 109 in phase 2. We had some standalone eye stents as well, like 3 in phase 1 and 11 in the other phase, but these were mostly already pseudophakic patients. But I know some people who do eye stents on phakic patients as well. Mean age was around 75 in both. Mostly females were included in the study. This is the laterality and diagnosis. As you can see, mostly were primary open angle glaucoma patients, but there were some angle closures and NTGs and others as well. These are the different surgeons. In phase 2, most of the surgeries were performed by myself, and in phase 1, there were other colleagues as well. This is the BCVA in phase 1 and phase 2. These, as expected, after any cataract surgery, there was a significant improvement in vision. This is the IOP results for phase 1. So you can see that our first audit actually achieved a result of 26% reduction in the pressure. And this is very interesting. In phase 2, you can see there is a trend of increasing reduction. So there's at first post-op month, there's 35% reduction, but it increases to 36% increase. I'll come to this in a few minutes when I come to the next slide. These are again the IOP trends. As you can see, there are different variety of pressures, maximum reaching up to 38 in phase 1 and 46 in phase 2. So the pivotal trial, 75% patients achieved a reduction of 20% in the pressure. In our study, as you can see, phase 1 achieved 75% at 1 year, and phase 2 had 80% reduction. So this is a very interesting result, especially in phase 2. As you can see, there is an increasing reduction in the pressure. These are the drops. So coming to that interesting point where we saw that the reduction in pressure showed an increased trend in phase 2. And the phase 2 patients were mostly done by myself. So I think I got a bit more brave in doing eye stents in a different kind of variety of patients, not just limiting them to primary open angle patients, as the ID pivotal trial did them mostly in mild to moderate primary open angle glaucoma patients and cherry picking them. But as we did them in advanced patients and patients not willing for trabeculectomy, so I think possibly there was a better absorption of medication post-surgery as well that led to this trend of improving pressures. So our paper has been accepted at EGS as well, so we can meet you there. If there is time, I can possibly show a small video of 10 seconds. Okay, that's fine. That's okay. Any questions? What is the price of this implant? Sorry? The price of this implant? Price is about 900 pounds. But if we compare that with the burden of the drops and other things, then I think in the long term, it becomes cost effective. No, possibly not in Pakistan, but abroad, yes. Thank you.
See that video, but unfortunately we have to wind up this session because after this is a plenary session. So sir, for a quick comment by our chair of the session.
So glaucoma, all we know that a difficult disease to diagnose, to manage, and the basic thing which we need is the clinical. We know all to diagnose and manage a disease. You know few things for that. Number one, knowledge. Without knowledge, you can't go forward. Number two, your clinical skills. your clinical skills are the most important one, because the diagnosis of any disease is depending upon your clinical examination. Your relevant investigations, they are going to aid up to your diagnostic abilities, but they cannot replace your diagnostic abilities. Regarding glaucoma, it is overtreated, it is undertreated, it is maltreated. Whenever one is in doubt, one should always go for another opinion, because we must be thinking from the side of the patient what at the end of the day he is getting. So with these remarks, thank you very much all the presenters. They added up to our knowledge. Thank you very much, the audience also.
Thank you very much, sir. The presenters are requested to kindly come and receive their shields from Professor Nasir Saeed Sahab. So one by one, I will request Dr. Yusuf Jamal Sahab to come on stage and receive his shield. Syed Imtiaz Ali Shah Sahab. Okay, Miss Rabia presented. Syed Imtiaz Ali Shah. And Dr. Noor Baksh Nizamani. So thank you very much, all the attendees, audience, for your participation and patience listening. Sir, thank you very much. So after this, we have the plenary session on Avastin. So all are requested to please be seated here and